Hi, this is Dr. Robert Gullberg giving a clinical infectious disease update on the use of antibiotics in anaerobic infections. I've been in practice for 28 years. We see a lot of these infections in the clinic as well as in the hospital. Let's talk about the different antibiotics that we use and a little about side effect profile and efficacy. Below the diaphragm, our anaerobes are primarily going to be in the B. frag group as well, or the Bacteroides group, as well as Clostridia. Metronidazole is basically our best antibiotic there, IV or oral. Watch for neuropathic changes as well as a metallic taste in the mouth, sometimes some nausea with it, but generally well tolerated. Other groups that we use are the second generation cephalosporin, cefoxitin or cefotetan, though the activity for the Bacteroides species isn't quite as good as Flagyl. Because it's a cephalosporin, you have to watch for diarrhea. Cefotetan, if that's used, it can cause some extra bleeding problems. The extended penicillins, such as Zosyn and Timentin, are outstanding for anaerobes below the diaphragm as well as above the diaphragm. And ticarcillin clavulanate, as well as piperacillin tazobactam, are mainstay therapies for intra-abdominal infections where anaerobes are involved. Watch for this typical problems with penicillins: thrombocytopenia, bone marrow suppression, skin rash, increased bleeding time, that type of thing. Of course, the penims, meropenem and ertapenem, doripenem, imipenem, and all the penims do great for anaerobes as well. So you can't go wrong with penem therapy if you're trying to cover anaerobes. Now, anaerobes above the diaphragm are going to be your Prevotella species, some of your oral Bacteroides above the diaphragm, the Peptostreptococci, Peptococci, the Veillonella species, and the Fusobacterium. These are generally sensitive to clindamycin. Amoxicillin can be effective, or penicillin, or augmentin. And now, of course, we've got the fourth generation quinolone, moxifloxacin. We're going to see anaerobic infections above the diaphragm in people with bad sinus disease, people with bad dental infections or abscesses, and people with aspiration pneumonia. So these agents are excellent above the diaphragm. Once you get below the diaphragm, we start losing efficacy there. Remember that metronidazole, though good below the diaphragm, doesn't have good penetration to the lung, so it's not a drug you're going to use in pulmonary infections whatsoever. So there's some good bullet points for you on anaerobes. Remember those as when you're on the floor. Thanks, Dr. Gullberg signing off.